Statins might be the most misunderstood drug in modern medicine. I've seen people refuse them and then regret it down the line. I've also seen others take them without really understanding why or what they're for. So before you take one or before you decide to avoid one, then watch this video, because if you've ever been told that your cholesterol is high, this stuff really matters, and it's worth spending the next few minutes really understanding it. I'm going to break this down properly for you. So what statins actually do inside your body, who genuinely benefits from them, and what the side effects really look like, which isn't what most people think. But more importantly, I'm going to explain the one concept that causes more confusion than anything else: the difference between relative risk and absolute risk. And this is something that so many of you have been asking for a long time. Because depending on how you hear that number, statins can sound either incredibly powerful or almost pointless. And at the end, I'll also share some lifestyle habits that, according to the evidence, are even more powerful than these drugs. By the end of this video, you'll know exactly where you stand. Hello, I'm Dr. Alex. I've been working as an emergency medicine doctor in the UK in the NHS for 10 years. And one of the things that I do regularly, more than most people probably realise, is discharge patients from the emergency department who've had some sort of warning event. So someone comes into the A&E with angina or a mini stroke, what we call a TIA, and they haven't had that full event yet. So the heart attacks and the strokes, they get admitted, obviously, they don't go home. But these other patients often do go home, and when they do, we almost always send them home with a statin, alongside other preventative medication. That is just how Western medicine works. Something happens, we prescribe you a medication, and then we send you home. And I've done this literally tens of thousands of times. So I'm very familiar with the common statins that we use all the time, like atorvastatin, simvastatin, rosuvastatin, what they do, what the doses are, and why we pick certain ones. But what you probably know if you've watched a few of these videos is that as I move more into lifestyle medicine, my goal now is to give you all of this knowledge to help you prevent these diseases that I see every day, and hopefully prevent you ever needing a statin in the first place. Because the stuff that I see every day in the A&E is pretty much entirely preventable in the vast majority of cases. And lifestyle can be more powerful than any medication I could ever prescribe you. That's what this channel is about. But despite that, some of you are taking statins, so let me give you all of the information that I think you need to know. So let's start with some context then, because the scale of statin prescribing is absolutely extraordinary. In England alone, atorvastatin had over 73 million prescriptions issued in a single year, making it the most dispensed medicine in the country, with more than 7 million people in the UK currently taking one. In the US, statins are the most prescribed class of medication overall, with around 40 million Americans taking them regularly. Globally, the numbers are just as staggering, and yet in my experience, talking to patients, most people leave their appointment with a prescription in their hand and only a vague idea of what it's actually doing inside their body. Most people think if they take a statin, they will never have a heart attack or a stroke, but it doesn't really work like that. Most people seem to know that it's about cholesterol, but most don't know much beyond that. And I think that gap matters because when you understand what something is doing, you're more likely to take it consistently. You're more likely to have a genuine conversation with your doctor about it and be better placed to make decisions about what else you can do. But before we understand what statins actually do, we need to understand cholesterol first, because it gets a bad reputation and it doesn't entirely deserve it. Cholesterol is a fatty molecule that your body genuinely needs. We all need cholesterol. It helps to maintain the walls of your cells, it's involved in making vitamin D, and it's a building block for several hormones. And here's something that a lot of people don't realise. The majority of your cholesterol in the body is not from food that you eat. It's made by your liver. Your body manufactures it because it needs it. But the problem isn't cholesterol existing. The problem is when there's too much of a specific type, what we call LDL, or low density lipoprotein, LDL, often called bad cholesterol, circulating in your bloodstream. Now, a few weeks ago, I actually did quite a detailed video on LDL, ApoB, and what actually drives your cardiovascular risk at a particle level. So I won't go into that again too deeply today. But the short version is that LDL is the type that can work its way into the walls of your arteries and begin causing damage over time. And that process is at the heart of why statins exist. That damage is called atherosclerosis, and understanding it changes how you think about everything else in this video. What happens is this. So when LDL levels are elevated over many years, some of it works its way into the walls of your arteries, the tubes that carry blood around your body. The immune system spots it and then sends inflammatory cells to deal with it. But instead of cleaning it out cleanly, what builds up over time is a mixture of fat, inflammatory cells, and debris that hardens into a deposit, what we call a plaque. This process is completely silent. It happens over decades with no symptoms whatsoever. You will not feel it developing, and the risk isn't just the gradual narrowing of your arteries. Plaques can rupture, and when they do, the body treats the rupture like a wound and sends clotting materials to seal it. That clot can then block an artery entirely. In the heart, that is what we call a heart attack. In the brain, that is a stroke. Now, these are the patients that I see in the A&E literally every single day, and this is the process that statins are designed to interrupt, long before it ever reaches that point. So here's what statins are actually doing inside your body. So your liver produces cholesterol using a specific enzyme called HMG-CoA reductase. Think of that as the production line. Statins essentially block it. They sit in that enzyme and slow it down. Now, because the liver is now producing less of its own cholesterol, it compensates by pulling more LDL out of the bloodstream to make up for the shortfall, if that makes sense. The result is that LDL levels in your blood fall significantly. These high-intensity statins, like atorvastatin at higher doses, can lower LDL by more than 50%. And lower LDL over time means less of it getting into your artery walls and less of the downstream damage that follows. Beyond that, statins also appear to help stabilize plaques that have already formed, making them less likely to rupture, even when the underlying damage can't be fully reversed. So the drug isn't just reducing your future risk, it's doing something really useful for the damage that has already quietly accumulated over the last few years. Now here's the part that I've got to be really clear about, because there's a lot of noise around this particular point. So in the UK, the NICE guidelines, NICE meaning the National Institute of Health and Care Excellence, these recommend statins for anybody whose 10-year risk of developing cardiovascular disease is 10% or higher. And we calculate this using a tool called Q-Risk, which takes into account your age, your blood pressure, your cholesterol levels, your family history, your smoking status, whether you've got diabetes or not, and then several other factors as well. In the US, the American College of Cardiology and the American Heart Association recommend statins for anybody with a 10-year cardiovascular risk of 7.5% or above, rather than 10%, as well as anybody who already has established heart disease or very high LDL or diabetes. But wherever you are in the world, statins are also routinely prescribed after a heart attack or a stroke has already happened, what we call secondary prevention. Secondary because we're trying to prevent that second event, where the risk is already confirmed and the case for treatment is even stronger. And when you look at the totality of evidence, everything that we have, not just a single study, not a skeptical blog post, but the large independent meta-analyses of randomized controlled trials, the picture here is consistent. In people who meet these criteria, death rates fall with statin treatment. If you've had a heart attack or a stroke, or if you're at high risk, if you take a statin, your chance of death will be lower. And this means fewer heart attacks, fewer strokes, fewer cardiovascular deaths. In terms of what this actually looks like in the numbers, for people who have already had a heart attack or a stroke, these statins reduce the risk of a further heart attack or a stroke by around 25 or 30% in relative terms. And in absolute terms, they can prevent another event in roughly 1 in 10 patients over 5 years. Now, for people who haven't yet had an event but are at elevated risk, The relative reduction is similar, but the absolute benefit is much smaller. And I'll get into more detail about this later on. And this is all because your starting risk is lower. The 29% figure that you'll sometimes see is cited specifically from a large meta-analysis of 21 randomized controlled trials, and it sits very comfortably within that range. And I'll explain exactly why the distinction between relative and absolute risk matters in a few minutes, because it's the thing that causes more confusion about statins than almost anything else. There will always be individual studies with more nuanced or conflicting conclusions. That is how science works, and that is a good thing. And I'll explain in a moment exactly why some of those numbers look smaller than people expect. But when the overwhelming weight of evidence points in one direction across dozens and dozens of large randomized trials, that is what we go with. That is the scientific standard, and this is where most of the pushback comes from. People point to concerns about dementia risk, or they look at the absolute risk reduction and conclude that the benefit is being overstated. And those questions are worth asking. They deserve proper answers. On the dementia point specifically, when you look at the best available evidence, large studies and meta-analyses do not show an increased risk. And some even suggest a possible protective effect, but it's an area that is still being studied, obviously. The important point to remember here is that one single study saying the opposite thing doesn't outweigh decades of consistent evidence. Yes, we've got to take into account whether pharmaceutical companies have had any influence in these trials, who led the trials, that sort of thing. But, we take all of that into account and we go with the balance of the best data available. And in this case, that still supports the use of statins in the right patients. And it's worth mentioning, obviously, that doctors in the UK don't get any extra money for prescribing medications or anything like that. Right then, let's move on to the side effects, because this is where a lot of the misinformation lives at the moment, and where a lot of people make the decisions to stop taking a medication that may genuinely be helping them. The most commonly reported side effect with statins, and I'm sure many of you can guess this, is, that's right, muscle pain. And it's the number one reason why people stop taking them. But here's something really important that often gets missed in the conversation. So, a landmark study in The Lancet found that less than 10% of the mild muscle pain and weakness reported by people on statins was actually caused by the drug itself. The other 90% appear to be caused by what we call the nocebo effect, the opposite of the placebo effect. Instead of feeling better because you expect to, you feel worse because you expect to. When people are told that a medication might cause some muscle pain, what we see in the research is that many of them do actually experience this muscle pain, even when what they're taking isn't a statin, it's actually a dummy tablet. And in the case of statins, which have been talked about in the media for years as causing these muscle cramps and aching legs, that expectation is already established before many patients take their first tablet. The nocebo effect is really, really powerful, and I actually did my first project on this in my first year of medical school. It is tremendously powerful. If you tell a patient that you might get some muscle pain in your legs, then so many more people actually get that because they've been told about it, rather than the true genuine side effect, if that makes sense. Now, proper statin-related muscle damage does happen, but it's rare. Around one person in every 10,000 per year. Now, to put that into perspective, if 10,000 people took a statin for 5 years, you'd expect around 5 cases in total. This is what the research tells us. Serious muscle breakdown, what we call rhabdomyolysis, is even rarer. If you have muscle symptoms on a statin, then obviously, despite what I've said, please tell your doctor rather than just stopping it. There are different statins and different doses and alternative strategies, but the idea that statins routinely destroy your muscles in most people who take them is not what the clinical trial data shows. What we also need to mention is that there is also a small but real increased risk of developing type 2 diabetes, roughly 50 to 100 extra cases per 10,000 people treated over 5 years. And that's still pretty low. For most patients at meaningful cardiovascular risk, the protection that it brings outweighs all of that. But it's still a conversation worth having properly with whoever prescribes it. Okay, let's move on to the practical side then. So what you can actually do, and this is the stuff that I just love talking about. So Whether you're already taking a statin or whether your risk is lower and it's not already prescribed yet, then there are a small number of lifestyle habits that genuinely move the needle. Now, these are not just general wellness advice that you'd hear from somebody on TikTok or whatever. These are interventions with large-scale clinical trial data behind all of them. The first one is the Mediterranean diet, so high in vegetables, fish, extra virgin olive oil, legumes, nuts, whole grain seeds, lower in ultra-processed food, and red meat as well. The PREDIMED trial, one of the most rigorous dietary trials ever conducted, found that people eating this way had around a 30% relative risk reduction in major cardiovascular events compared to a control diet. A meta-analysis pulling together 4 major randomized controlled trials covering over 10,000 people found that this diet roughly halved your odds of a major adverse cardiovascular event. Now, those are not small numbers. The second one is regular aerobic exercise. Consistent, moderate aerobic activity where you get your heart rate up independently improves your blood pressure, your lipid profiles, your insulin sensitivity, and your vascular function, simultaneously across the board without a prescription. And the third one, obviously, is not smoking. Within a year of quitting, the risk of a heart attack is cut roughly in half compared to somebody who still smokes. Now, that effect size is really hard to match with any single drug. And the fourth one is achieving but also maintaining a healthy weight, particularly reducing the amount of visceral fat that you have, the fat that sits around your organs and around your midsection. What we know is that excess visceral fat drives LDL, it drives your triglycerides, your blood pressure, and your insulin resistance all at once. And meaningful weight loss, where you lose weight from around your midsection, moves all of those in the right direction at the same time. And I did a video on this a few weeks ago about how to reduce your visceral fat if you want to check that out. Now, these 4 things that I've mentioned really briefly in this video are not alternatives to a statin in these high-risk patients. They are what work on top of it. The people who do best long-term are almost always doing both. The tablet doesn't replace the lifestyle, it works alongside it. But in a low-risk patient, there's no denying that doing all of these together would be more powerful, according to the evidence, compared to taking a statin. This is the part that everybody seems to ask about in the comments: absolute risk versus relative risk. Basically, how much benefit does a statin actually give you? This is where the numbers really matter. So when you hear that statins reduce the risk of a heart attack by 29%, that is a relative risk reduction. People who are skeptical of statins then point out that the absolute risk from the same study, this large meta-analysis of 21 randomized trials, was actually 1.3% for a heart attack. So which number is true, 29% or 1.3%? Well, the answer is both of them. They're measuring different things, and understanding the difference is one of the most useful things that you can take away from this video, for statins, but also for interpreting any health research you come across. Now, here is the simplest way that I sort of think about this. Imagine 100 people with a moderate risk of a heart attack. Over a number of years, 4 of them have a heart attack. You give a similar group of 100 people a statin, and only 3 of them have a heart attack. Now, that is a 25% relative risk reduction. Going from 4 to 3 is a 25% reduction. But the absolute risk reduction is 1%. 1 fewer person in 100. Now, imagine the starting risk is much higher. 20 out of every 100 people have a heart attack without treatment. If you apply that same 25% relative reduction, then you've prevented 5 heart attacks. The same relative figure, but 5 times the absolute benefit, if that makes sense. And this is the whole point. The absolute benefit of a statin depends almost entirely on how high your underlying risk is in the first place. For someone who has already had a heart attack, the absolute benefit is really massive, actually. Statins can prevent cardiovascular events in roughly 1 in 10 such patients over 5 years. For someone who's got a much lower background risk of a heart attack, Being offered a statin primarily on the basis of a single cholesterol reading, the absolute benefit over the same period is much smaller. So the honest answer is not that statins are useless or that they are miraculous, it's that the benefit scales with your risk. The higher your underlying risk, the more a statin actually does for you in real, absolute terms. And that is why your doctor should be calculating your personal risk before prescribing one, not just handing out tablets based on a number in isolation. And it's worth being honest about why relative risk figures tend to be the ones that get quoted most prominently. Let's be honest, a 29% reduction is a more compelling headline than 1.3%. And it matters when drugs are being marketed, when guidelines are being justified, and when patients are being convinced to take something. Now, that doesn't mean that the relative risk figure is wrong, or that this approach is correct, or that the drug doesn't work. The drug does work in the right patients. It just means that you deserve to know both numbers and which one actually applies to somebody with your level of risk. It's all about transparency. So then, to bring all of this together, statins block the enzyme that your liver uses to produce cholesterol, reducing LDL in the bloodstream and slowing the process of atherosclerosis, which is the silent, decades-long build-up that leads to a heart attack and stroke. The overwhelming evidence from large, randomized trials, and that's important, shows that in people with moderate to high cardiovascular risk, statin treatment reduces death rates. We can't really argue with that, even though the occasional study comes out saying something different. The muscle side effects are real, but far rarer than most people believe, and the nocebo effect plays a much larger role in what gets reported than most patients are told. The absolute benefit of statins scales with your personal risk. The higher your risk is, the more meaningful the protection becomes. And the 4 habits that sit alongside it, so the Mediterranean-style eating, regular aerobic exercise, not smoking, and maintaining a healthy weight, for most people, these are not optional extras. They are the most powerful tools available, backed by some of the largest trials in cardiovascular medicine. And as a doctor who has sent hundreds and hundreds or even thousands of patients home with a statin in their pocket, my honest view is that the tablet and the lifestyle work best together, and that the lifestyle done consistently is the part that most people underestimate. If you've been offered a statin and you're not sure, then ask your doctor about your 10-year risk score. Ask what the absolute benefit looks like for somebody with your profile. Ask what lifestyle changes would move that needle alongside it. That is the conversation that will really help you decide. I really hope you found this video useful today. Lots of people have been asking for this sort of information. If you did find it useful, then please like the video and subscribe to the channel. It really does help so much, and it allows me to keep making these videos for you. Thank you again, and I'll see you in the next one.